day to all. Today I am going to speak on Intra Aortic balloon pump, means IABP. It's a temporary support for the left ventricle by mechanically displacing blood within the aorta. It is most common and widely available method of mechanical circulatory support system. It works on two concepts: systolic unloading and diastolic augmentation. And traditionally it used in surgical and non-surgical patient with the cardiogenic shock, which is the most common indication of the IABP. So before going in detail, I give the brief about the history of this IABP. In 1952, Kentrovitz described the augmentation of coronary blood flow by retardation of arterial pressure in animal models. And after 6 years, Harkin suggested the removal of some part of blood volume via the femoral artery during systole and replacing the same volume rapidly into diastole for the treatment of left ventricular failure. This is called as a diastolic augmentation. And in 1962, Dr. Molopoulos and colleagues developed the experimental prototype of an IABP whose inflation and deflations were timed to the cardiac cycle. And from this, after 6 years, the first clinical trial of IABP has conducted, and after 1 year, Datascope has make it commercially available for the use in clinical practice. In 1979, after 10 years of the first commercially available IABP, the introduction of percutaneous catheter for the IABP by Bergman and colleagues, which is easier and quicker to insert and with the dual lumen catheter, which we will see in the later part. So the basic principles of counter pulsation which is used for the IABP working. So counter pulsation is the term that describes the balloon inflation in diastole and the deflation in early systole. So balloon inflates causes the volume displacement of blood within the aorta, both proximally as well as distally, and this lead to the potential increase in the coronary blood flow and potential improvement in the also other systemic organ perfusion by augmentation of intrinsic Windkessel effect. This IABP have a primary effects mainly on the ventricular performance of the failing heart by facilitating the increase in myocardial oxygen supply and decrease in the myocardial oxygen demand. So how it increase the myocardial oxygen supply? By increasing the coronary blood flow. In the same time, it reduce the afterload and reduce the left ventricular workload, thus it reduce the myocardial oxygen demand. So the hemodynamic effect with the IABP therapy is on different organ is different. In aorta you will get the reduce in the systolic pressure and increase in the diastolic, specifically the augmented diastolic pressure. And in left ventricle it reduce the systolic pressure and diastolic volume and left ventricular wall tension. On the overall heart effect is it reduce the afterload of the heart, reduce the preload of the heart and improve the cardiac output for the heart. And coronary blood flow also increase with this IABP. So if you see here what the effect of specifically balloon inflation and balloon deflation. Balloon inflate during the diastole, so it gives the augmentation of diastolic pressure and thus increase the coronary perfusion, and by this increase the myocardial oxygen supply by increasing coronary perfusion. And during systole, balloon gets deflated and it decrease the afterload, it reduce the cardiac work and reduce the myocardial oxygen consumption, and by these two effects ultimately it increase the cardiac output. So after starting the IABP, the early effect of the IABP is it reduced the systolic blood pressure by 20%. It increased the aortic diastolic pressure by 30%, by raising the coronary blood flow. It increased the mean arterial pressure. It reduced the heart rate by 20%. It decreased in the mean pulmonary capillary wedge pressure by 20% and elevation in the cardiac output by 20%. So predominant effects of this IABP is enhancement of the left ventricular performance. It also has favorable effect on the right ventricular function by accentuation of right ventricular myocardial blood flow as well as unloading of left ventricle causes the reduction in the left atrial pressure and pulmonary vascular pressure, thus reduce the right ventricular afterload. So by these two effects is also help in on the right ventricular functions. So you may we can also use for the right ventricular dysfunction, specifically when it is associated with the left ventricular dysfunction. IABP inflates at the onset of diastole and thereby increase the diastolic pressure and deflates just before the systole, thus reduce the LV afterload. IABP also counteracts the failing compensatory mechanism in shocks such as the peripheral vasoconstriction, tachycardia and neurohumoral hormonal activities. So factors responsible for the IABP effects are balloon volume, heart rate and aortic compliance. These these 3 points affects the balloon IABP augmentation as well as the IABP effects. So balloon volume is amount of the blood displaced is proportional to that balloon volume. So if this volume is low, then this diastolic augmentation might be low, or balloon will not properly affect the hemodynamics. The heart rate, if tachycardia is there, it reduces the diastolic time. Thus, LV and aortic diastolic filling times are inversely proportional to heart rate. Thus, it reduces the balloon augmentation. And aortic compliance, the same. If aortic compliance is high or very low, that will also affect the balloon by reducing the balloon effect. So indications of this IABP are, most common indication is the cardiogenic shock. When cardiogenic shock is due to the acute MI or due to the acute MI complications like acute MR or VSR. It is also used during the CABG preoperative and postoperative insertion. Preoperative mainly when there is patient with the severe LV dysfunction with the poor hemodynamics and patients with the intractable ischemic arrhythmia in preoperative period. After cardiopulmonary bypass, if post-cardiotomy cardiogenic shock is there, the balloon will also helpful to take the patient wean from the CPB. In association with non-surgical revascularization, it is very useful, specifically with the coronary angioplasty when patient is hemodynamically unstable MI patients going for coronary angioplasty. Also helpful when the high risk coronary intervention like severe LV dysfunction is there, left main coronary artery disease is there, or complex coronary artery disease is there. When these patients are going for angioplasty or some other intervention, we can support it with the hemodynamic with the IABP. Other uses of this IABP are stabilization of the cardiac transplant recipient before insertion of the VAD. So when these patients require the ventricular assisting device, better to stabilize it with the IABP insertion. Sometime post infarction, you are not planning for immediate revascularization and patient having the angina, you can use this IABP. And also ventricular arrhythmia related to ischemia which is not responding to the medical line of treatment. Some contraindications are absolute and relative. Absolute are mainly the significant aortic regurgitation is there, aortic dissection is there, or aortic stenting is there. We should avoid the use of IABP balloon. And if patient has a femoral popliteal bypass grafting is there in severe PVD disease, we should avoid the femoral route for the insertion of the balloon. Some relative contraindications like abdominal aortic aneurysm, uncontrolled septicemia or uncontrolled bedding diathesis is there, we should avoid. And severe bilateral peripheral vascular disease, we should also avoid in such cases. When you decide to insert the IABP into the patient, you have to properly assess the patient before inserting the IABP. So we have to assess both the leg of the patient for skin color, skin temperature, capillary refilling ability of both the legs, quality of pulse in both the lower limb, baseline sensation and movement of both limbs, and ankle brachial index of both legs. Normally it is 1.3 to 0.9. If it is less than 0.9, we should avoid that route, specifically the femoral route, because of this low index. Also see the pre-insertion hemodynamics of the patient. Complete neurological assessment of the patient is required, and most important, you should counseling the patient or the families regarding the effect of IABP and what are the complications associated with this IABP. So instrumentation of IABP includes the two main components: double lumen flexible catheter which has the balloon at the distal end, and other is the mobile console with the pump to drive the balloon. This catheter has a two lumen, one for the gas exchange and other for the monitoring central aortic pressure. And that catheter is made up of polyethylene and cylindrical in shape with radio opaque tip on the balloon. And helium gas is usually preferred because it is a inert gas, low density and rapid diffusion coefficient. So it easily moves in and out during balloon inflation and deflation. And optimal 85% of the aorta should occluded with this balloon. No need to occlude the 100% of aorta. This IABP kit has a two box. One box contains the guide wire, dilators, sheath for balloon insertion, gas tubing and three-way stopcock, and the other on the right side it includes the IABP catheter at whatever size you selected with the 60 ml syringe. So this IABP catheter usually inserted with the Seldinger technique, where you first puncture the vessels and then insert the guide wire, remove that needle and insert the dilator to dilate the tract into the skin. And after this dilatation, either you use the sheath to insert the balloon, or you can also directly insert the balloon as a sheathless balloon. In our institute we commonly use the sheathless balloon. Very few indications where we are using the sheath for the balloon insertion. After inserting the balloon, the most important thing is to connect this balloon properly with the console. Connect the this helium gas tube, one end to the catheter and other end to the this console, from where the helium is moved in and out, and at the same time open the helium tank. And the other connection of the catheter is the central lumen, which is attached with the three-way stopcock and then connected with the pressure tubing to the transducer, and properly aspirate it and remove the all air and do the de-airing of that line, and then zero the transducer. So we will now get the arterial line trace on the balloon monitor. So initial setup required for the starting of this balloon is, once you properly connect the console, you should also show the check for the ECG and pressure waveform on the balloon monitor. Check the basal mean pressures. Make sure the settings is on the auto. First, when we start, it should be with the auto mode from the balloon. And usually IABP initially start with the 1:1, and if it is tachycardia is there, we can start with the 1:2 augmentation. And usually augmentation is percentage is kept maximum at the starting of the IABP machine. This slide shows the how the IABP is totally connected. The balloon part, first part, which is in the aorta in the body, and the second part of that catheter, which is outer part, which has a two connection, which usually we fix on the leg in case of femoral insertion, and the one end which is connected to the transducer for the arterial pressure line monitoring, and the other end is connected to the console for the helium in and out movement. When we use the IABP, the sizing of this IABP is very important. It is based on the patient's height. There are four sizes commonly available, is the 30 cc, 35, 4 cc, 40 cc and 50 cc. So this balloon length and diameter increase with the each larger size. Pediatric balloons are also available in the size of 2.5, 5, 12 and 20 cc. The same it is like the adult, but the size of the balloon is smaller. After inserting the IABP, we have to confirm the position of the IABP. There are a few modalities from where we can confirm. First, commonly we use is the measuring the IABP length from tip of the IABP from the sternal angle of Lewis to the umbilicus, and then obliquely from umbilicus to the femoral insertion site. This is commonly we use this in the operation theatre and in the bedsides. If we are inserting the IABP into the cath lab, the fluoroscopy is a very good guide for the insertion of IABP and positioning of the IABP. Also we can use the T in the OR and in the ICU, where we visualize the tip of the catheter 1 centimeter distal to the left subclavian artery. For this we have to locate the descending thoracic aorta in the T. And when routinely in everyday monitoring, we have to go for the X-ray, where the radio opaque tip we can see in the around the second intercostal space just above the left main bronchus, which correspond to the angle of Lewis, and lower end of the balloon should lie cephalic to the renal arteries. This is the routine we have to go on the patient with the IABP in the ICU to everyday check for the radio opaque tip should be in the proper position, so the balloon is properly placed and it working properly. Balloon works on the trigger. So what is the trigger? Trigger is the event that pumps used to identify the onset of cardiac cycle. So this balloon works with the cardiac cycle. So we have to provide any one trigger where the IABP detect the onset of cardiac cycle. So commonly 4 triggers are available in the IABP machines: ECG, arterial pressure waveform, an internal trigger, or maybe if we have added the pacer, so we have a pacer mode also in the as a form of trigger. So ECG, it uses the slope of QR segment to detect the triggering point. And in arterial pressure waveform, it uses the systolic upstroke of the arterial pressure waveform as a trigger. And internal trigger we usually use when the CPR is going on, so it gives at the fixed internal rate the balloon gets inflation and deflation. And it also trigger with the pacing wave for ventricular pacing or AV sequential pacing. But timing of this inflation and deflation is very important. When we start with the auto mode, the balloon automatically will detect the trigger from the trigger where they need to where the balloon should inflate and where the balloon should deflate. But when we use the semi-auto mode or manual mode, it is very important to set this timing. So when the balloon gets inflated, balloon inflate normally after the closure of aortic valve, and it deflates just before the opening of the aortic valve. So this is by the ECG or arterial line trigger. So inflation occur on the ECG at the middle of T wave, or in arterial pressure at the dicrotic notch, and deflation occurs on the ECG at the peak of R wave, and in arterial pressure wave just before the next upstroke starts. So here you can see in the graph the light blue area where the in arterial line dicrotic notch the balloon gets inflated, so the diastolic augmentation is there, and it deflates just before the starting of the next systolic upstroke. This is the normal IABP pressure waveform. First you can see the normal arterial pressure waveform, and in second, where at the dicrotic notch the balloon gets inflated and you have the diastolic augmentation, and then sudden fall in the diastolic pressure as the balloon deflates just before the next upstroke. So this is the first part wave. You can see the unassisted systolic and unassisted diastolic pressure. In the next wave you can see the diastolic augmentation, that is the top high pressures, and at the lower you have an assisted end diastolic pressure, and after the that last wave is the assisted systolic pressures. How you can diagnose this augmentation of balloon is very effective. You have a few points on the graph, from that you can see the augmentation is proper. First thing is a sharp V wave at the point of inflation. You will get this at the dicrotic notch, the sudden upstroke, so you have a sharp V wave at that point. The other point is diastolic augmented wave is more than the systolic waves. So diastolic augmented wave after dicrotic notch, it should be more than the previous systolic wave. A proper acute fall of deflation slope. Assisted aortic end diastolic pressure should be less than unassisted aortic diastolic pressure by 15 mm of mercury, and same assisted systolic pressure should be less than unassisted systolic pressure by 5 mm of mercury. this balloon, if in auto mode, usually inflates at the proper time with the triggering factor, but when we put on the manual or semi auto, we have to also adjust the inflation and deflation time according to the IABP arterial line trace or with the ECG. If it is not properly inflate or deflate, we have some issues with that. So we can go one by one. If that balloon inflates early, what could be the problem? How will you know this is a early inflation? You can see from the waveform of the arterial line. The inflation of IABP prior to the dicrotic notch occurs, and this leads to dicrotic augmentation encroaches onto the systole. So may be unable to distinguish from this systolic and diastolic augmented wave. It causes the potential premature closure of the aortic valve. So potential increase in left ventricular end diastolic volume, left ventricular end diastolic pressure and pulmonary capillary wedge pressures. It also increase left ventricular wall stress or afterload aortic regurgitation, or ultimately it increase the myocardial oxygen demand. So balloon inflation should not occur earlier. Late inflation late inflation also affects the balloon function. Inflation of the IABP markedly after the closure of the aortic valve, not immediately after the closure. After some time it inflates. So waveform characteristic of this is inflation of IABP after the dicrotic notch, not the normally inflation occurs at the dicrotic notch. Here in figure you can see it inflates after the dicrotic notch. This will lead to the suboptimal diastolic augmentation, and this ultimately cause suboptimal coronary artery perfusion. So your goal of diastolic augmentation will not achieve with the late inflation. If it deflates early, then premature deflation cause the deflation of IABP is seen as a sharp drop following the diastolic augmentation. Suboptimal diastolic augmentation, assisted aortic and diastolic pressure may be equal or less than the unassisted aortic and diastolic pressure, and assisted systolic pressure may rise than the normal. So this early deflation causes the suboptimal coronary perfusion, potential for retrograde coronary and carotid blood flow. If this retrograde blood flow occurs, that will precipitate the angina and also the suboptimal afterload reduction, and ultimately it increases the myocardial oxygen demand. If this balloon deflates late, this issue is that also causes the afterload reduction in essentially absent. So we will not achieve the afterload reduction if it deflates late than the normal. It also increases the myocardial oxygen consumption due to the left ventricular ejection against the greater resistance and prolonged isovolumetric contraction phase. IABP may impair the left ventricular ejection and increase the afterload if it deflates late. Even with the normal timing, if these timings are proper, working on the auto, deflation, inflation and deflation at proper time, but still your diastolic augmentation is poor, there may be some issues like patient with the extremely low cardiac output, patient have a low SVR, balloon may be too small for the patient, or balloon position is very high or very low, so will not get the proper augmentation. Balloon not completely out of the sheath when we use with the sheath, or balloon not wrapped up fully from the normal position, or maybe the dropped the helium pressure, so helium is not properly going in and out of the balloon. After this normal arterial deflation, inflation and deflation, we can also find out some issues with the this balloon waveform, which we get just below the arterial pressure waveform. So this is the normal waveform as a just upstroke and then plateau and then downstroke, that we can easily see on the IABP screen. But when these plateau pressures is low or high, some issues are there, like low IABP balloon plateau pressure due to the balloon is too small for that patient, or hypotension, low SVR, low cardiac output, or balloon position is too high or too low, then we will get the this plateau pressure lower than the normal, and this lead to the decreased diastolic augmentation. So our goal of diastolic augmentation will not achieve if these problems are there. This petupulation may go high than the normal. This is due to the balloon is too big or IABP is not fully unwrapped in from the normal. Hypertension is there, balloon position is too high or balloon catheter is kinked. This leads to the rupture of balloon or injured aorta, or it may also increase the afterload in the of the heart. If this balloon has a filling pressure which is low due to the helium leak or loose connection, then there is a failure of auto mode. The auto mode will not properly work because of the leak, and this filling pressure is very low than the normal. And when this filling pressure is high due to the balloon catheter kink or IABP console malfunction, this balloon get rupture or it can injure the aorta, and it also increase the afterload of the heart. So this IABP after insertion and regular on the ICU, we have to manage this patient specifically with the anticoagulation and proper examining the patient for every day. So anticoagulation require is the 5000 international unit of unfractionated heparin immediately at the time of IABP insertion, and followed by infusion at 500 units per hour. And for this anticoagulation, we have to monitor the APTT and ACT. APTT should be 1.5 to 2 times than the normal. ACT we have to maintain 150 to 180 seconds. Every day we need to go check the IABP position with the chest X-ray. There is radio opaque tip which should be at the level of second intercostal space. It should not go up or down. Otherwise, we have to stop the balloon and do the proper positioning of the balloon. Every day we have to check the peripheral pulse, especially with the manually or with the arterial Doppler. Every 2 hourly we have to check and monitor on the we have to note down the pulse on that IABP limb, and any color change or temperature, that also we have to see every day. Patient position is very important on the IABP. We have to restrict the hip flexion of that inserted limb, and head up should not more than 30 degree. When we keep the IABP on standby, should not be more than 20 minutes, as it increases the chance for thrombus formation on the balloon. And daily we need the hemoglobin monitoring to check for the hemolysis, platelet count for the HIT, and also the renal function to check the any catheter migration and leading to the urine AKI or not. This balloon has some issues which display on the monitor due to some troubleshootings, like no trigger. Why this no trigger? What do you mean by this no trigger? This means that the IABP has lost its triggering of ECG or pressure and is unable to time the inflation and deflation of the balloon. So we have to check for the ECG lead and pressure cable, and if it is disconnected, we have to connect, or we have to change the ECG lead, or may require to change the transducer for the pressure line monitoring. If it shows the check the IABP catheter, this means the IABP catheter is either kinked in situ or at the insertion site, or it has not properly unwrapped from its normal position. So the action required for this is examine the catheter and extension tubing for any sign of kinking. Ensure that full augmentation is there. Making sure that the balloon has ability to expand means it is fully open, not unwrapped. And examine the skin insertion site, which is the common place for the kinking. You may also see the sometime message of rapid gas loss. This will appear if there is a leak or hole in the balloon or extension tubing. This means the balloon may be ruptured, or will see flecks of blood in the tubing if it gets ruptured. If the balloon is losing its gas and filling is frequently necessary, or blood flecks have identified in the tubing, then stop that pump and need the remove of that balloon and replace with the other balloon. Check the all connection for any other leaks or disconnection is there or not. And if you find out the IABP disconnected message, this means the IABP catheter extension tubing has been disconnected and pump will stop working. So you have to again reconnect that extension tubing, press the IABP fill button for 3 seconds till it gets filled, and then press start or standby button for working of the IABP machine. IABP has some complications, especially the vascular complication, mechanical complication, and some life-threatening complications. Vascular complications are the limb ischemia, and sometimes this leads to the require the embolectomy, MA, or amputation. Systemic embolization due to the rupture of the balloon may be there. Bleeding at the insertion site, thrombocytopenia, hemolytic anemia, and stroke also with this IABP insertion. Some mechanical complications related to the balloon are balloon get rupture or balloon leaks, balloon displacement. Sometimes it leads to the inadequate diastolic augmentation. So our goal of IABP should not be properly achieved with this improper augmentation. And sometimes the clot formation on the pressure in the pressure line, so you will not get the proper monitoring, or if the same time if your ECGs get disconnected, you will have no trigger on the pressure line. Some life threatening complications are aortic dissections, aortic rupture, infection, and compartment syndrome also may be there. After IABP properly works, we have to everyday assess and find out what is the ideal time to start the weaning of the IABP. So with the IABP, your inotropic requirement should go down. Patient should remain stable for 12 to 24 hours with that IABP and low inotropic support. Then you can think for the weaning of IABP. For weaning, first you have to change the pump ratio from 1:1 to 1:2 or 1:3. Then decrease the augmentation percentage, and the same time you monitor the patient closely. During this time, patient should remain hemodynamic stable. If patient become unstable, weaning should stop immediately. Once you decide to the removal after weaning removal of IABP, discontinue the heparin 4 hours prior to the removal, and disconnect the IABP catheter from the IABP pump. Patient blood pressure will collapse this balloon membrane once you disconnect from the console before withdrawal, and remove the IABP catheter and the sheath if it is there as a single unit, and after removal give the proper compression over the insertion site for at least 20 minutes, and after that check there should not be any bleeding or hematoma after 20 minutes, and also check the adequacy of limb perfusion after hemostasis is achieved. Thank you.